In 1995, the government issued a call for proposals for what turned out to be 6 centers of excellence across the country. And we are the only one really that still exists in Canada. So I'm really proud of that. I'm really proud of the fact that we still carry on and we've changed a lot with the times. But really, our base was at that point responding to what became the Women's Health Strategy in 1999 in Canada and all of the agenda items that were underneath it.
It was interesting that the Center of Excellence that we're connected with, now called the Center of Excellence for Women's Health, was the only one of the Centers of Excellence that was connected to a hospital.
That's right.
It really made a difference, I think, to
It did.
push it not from a university context, but from actual connection to clinical care and health policy thinkers.
Exactly.
I remember some of those early conversations we'd have around the big table at the center, and it had all kinds of different women thinking through and trying to prioritize what research questions will we ask, what do we need to know, who's going to do what. And it was such an interesting collaborative context for us to think through, well, how does the clinical question fit with the community woman's interest and the woman with lived experience?
We've talked about our involvement model a lot over the years and how it brought together different kinds of women and women's groups and, from advocates to policymakers. But, in essence, it really is based on some very old notions about talking.
I guess I just feel it really goes back to the women's movement and that initial work that women did in what we call consciousness raising groups, right? And that was really a way of women coming together and telling their stories to each other, listening to each other, and kind of bringing those stories together and synthesizing it and kind of making it into very much like research in the sense of coming up with a theory of what underlay all of those stories. I remember it especially in the case of violence against women. It was such an important thing to early on tell each other about those experiences which had not been heard or written about and became the basis of the violence against women's movement. Those were really interesting times, and I feel like that is what makes us more of a feminist research group rather than a generic research group, because that underpinning of it being about women's health and women's stories, pulling that up and closing the loop between the formal kinds of research and the implications for how the world needs to change to be more responsive to women's health and women's experience of violence, for sure.
Yeah, I think that's really important. And that process occurred on so many topics, For example, how women were being prescribed drugs or how women were experiencing the fitness movement or the sport movement, often not very well, feeling excluded or body shamed or in some cases abused. Or how women experience childbirth, which in many cases there were many horror stories attached to. But as you say, they hadn't had a chance to share those stories until kind of that women's health movement allowed for that in the sense of providing the context and the opportunity. And I think at the Center of Excellence, our hope was that we could maintain that line of and access the wisdom of the women who were experiencing these kinds of things, good and bad, and try and make structural change. We've come a huge way in Canada, but the problem hasn't gone away.
Yeah.
So these things are still so pertinent to me, and I think to women in general. Women who weren't even born when these issues were first raised are now experiencing them anew.
Yeah. The thing that I think is interesting is just that as a center, we had that vision that we could make change. And it was important to press against the way things were being delivered. And it wasn't, an angry thing as much as it was, you need to listen to us and we can help you redesign the way you respond on women's health. And I think that that's the thread that's carried through that I think is really important, is that vision that it can be better, and really honoring the fact that there's a lot of people who need to come to the circle to make it better, and that the policy analysts and health system planners did need to be at the table with the clinicians and service providers, with the women with the health issues, and with us as researchers.
It's so true. And I remember at one stage around 2010, maybe, our tagline was women's health, everybody's business.
Yeah.
And I think that was so true. It was a real breaking through of that notion that women's health really had to be fixed just by women. It actually had to be fixed by everybody. And it could be if people understood it as part of our social fabric and part of our economy and a part of our general well-being as a country. And I think that takes us back to our involvement model too, to say we value all kinds of information, from wisdom, lived experience, living experience, two-eyed seeing in science, knowledge keepers, wisdom, all kinds of it has come to our tables, either virtually or in person, to try and influence how those policies get done or retracted and how those practices might change. So, in the last few years, we've really solidified our work into three major themes or areas. One is advancing sex and gender science. Another one is really doing a lot of work to support sex and gender based analysis plus, which is mandated in Canada. And the third item has been really pushing forward the notion of taking gender transformative approaches to health issues in general. So let's talk about those three things. The first one, advancing sex and gender science, is really crucially important, because what we found over the years is that when it came to looking for evidence on certain matters to try and improve women's health, it wasn't there. And that meant there had been deficiencies in the way science had been done. And luckily, with the advent of the Institute of Gender and Health, we've had a real push in Canada to try and improve the integration of sex as a biological variable and gender as a social variable into all health research.
And I think what's been really interesting in that process has been thinking through not just the science about sex differences, but much more thoroughly thinking through what are the sex factors and gender factors and influences that matter.
That's right.
And I think that's really been the biggest hurdle we've had in trying to help people understand what we're doing and why we're doing it. That it's not just a comparison thing, like there's a generic human being and they're comparing against that. But it's really trying to get to the essence of what matters.
Right, you're quite right. And that sex plus gender impact can be seen in so many different areas. Where you really do have to become more and more familiar with bodily processes, such as metabolism or genetics or anatomy, as well as social processes like gender roles, gender norms, gender identity, and the overarching principles that really come into it when we take an intersectional approach. And that is, how does sexism and racism and discrimination factor into all of that? That's really the challenge of sex and gender science. It leads us ultimately to personalized medicine and to better healthcare for individuals if we do it right.
Having that commitment to thinking always about how different people women, men, boys, girls, gender diverse people, and how their experiences really matter and how important it is to look at those things in all the research that we do and consider what matters in this context and how might we then make policy or change health practice to really take into account some of the ways people experience the world. And that can be because of trauma or because they live in a rural location or because of race or class. And I just think that we've become so much better at doing that kind of analysis and how important it is to do it.
It really shines a light differently, I think, on so many current health issues, whether it's vaping or whether it's COVID transmission. We've done sex and gender-based analyses on tobacco policy, for example, on drug policy, on prescription regulations of prescribed drugs. We've taken a look at health promotion from this point of view. We've analyzed messages and campaigns to try and get people to do things differently or behave differently. And really, I think, contributed to trying to take the pressure off individuals being asked to change when, in fact, so many social factors affect whether or not they can.
Yeah.
And whether or not it's their ultimate responsibility to take the first step, or whether or not we need to change structures and processes around them and take that on as a society. It sort of leads us into the third area, too, that when we think deeply about health promotion, we really are forced to think about how we can make it better, which is the title of this book, which we did on gender transformative health promotion, just to really force ourselves to think through, okay, how can we do health promotion that improves health, but also improves gender equity at the same time? And in this book, we had several authors help us give examples of that, whether it be in tobacco or alcohol, or whether it be in fitness areas, or whether it be in mental health for immigrant women, or anywhere. We went all over the map in this book, just trying to figure out how we could raise the bar on women's health promotion. And, that sounds easy to do, but it's very hard, because typically we're not thinking about improving gender equity at the same time as we're thinking about improving health. And gender transformative work forces us to think about those two things together. It really takes us into a lot of new territory, gender transformative work, including the engagement of men and boys in righting some of the wrongs in the past around women's health. And also really invoking the notion of how healthcare providers and health promotion people can be transformative as opposed to gender neutral, which we say is not helpful at all, and be more and more precise about how women experience the world as part of their health and vice versa, and to try and get at what structural solutions could help here. But I think, gender transformative work has really widened our views too about the role that everybody has, especially men and boys, in terms of improving women's health, and how systems and policy planners have a huge role as well. It's really pinpointed what some of the issues are structurally.
It's been really interesting having the chance to be a bit more national in focus around engaging with the Nunavut government, the New Brunswick government, the Nova Scotia government, all the prairie provinces as well, and really thinking through how are you working on either substance use issues or trauma related issues, etc. It's been really important to get to that deeper level of saying what's the structural issue and how can you, as governments as well as service providers, really make a difference beyond just adding a group here or a pamphlet there kind of approach.
And it's interesting to me too how it really does force all parties to link together our three areas of sex and gender science to get the evidence for change, SGBA plus, the sex and gender based analysis plus, as a skill to try and get people to understand how to apply it in their own work in order to feed a gender transformative answer or solution. That you really can't have one without the other. And I think that is also one of the ways in which the field is so much more complicated than it used to be 25 years ago. It really does need critical thinking, more analysis on the part of every worker, every policymaker, every politician, even every researcher to think through how both social and biological issues factor in to health for anyone, actually, not just women, and how structural problems are going to continue to create poor health for so many people unless we fix them. And so, one of the things that we're doing now and looking ahead is working on how SGBA plus EDI works together. That is equity, diversity, and inclusion. And I think we have a role to play there in making sure that these concepts are merged as we go forward.
Coming back to where we started with, continuing to be hopeful and thoughtful and active, to look at all the intersectional and other issues that face us now and that we understand better as they interact with sex and gender really keeps us going.
I don't see any let up in this work. I think there's a huge amount to do. And I think it behooves us as a women's health center to keep identifying how girls and women still experience gender inequity.
Yeah.
I think we can contribute a lot to how all genders experience gender inequities in various ways, and how sex and gender science can address both male and female bodies, and also men and boys and gender diverse people, as well as girls and women. But our central work is to try and make sure that girls and women's health improves in the next 25 years.